Hi friends, myself Dr. Sandeep. Today let's discuss about aplastic anemia. Aplastic anemia is a pancytopenia with hypocellular bone marrow with absence of abnormal infiltrate and no increase in reticulin. Epidemiology. It is more common in Asia, it is more common in India. It is a bimodal distribution. It has a two peaks, one peak less than 25 years and other peak above 60 years. In India, we see about 6,000 to 8,000 patients per year. Etiology and classification. Etiology, it might be acquired or inherited. Most common is idiopathic, up to 60 to 65%, followed by secondary causes such as radiation, drugs and chemicals, viruses, Epstein-Barr, hepatitis, non-A, non-B, non-C, parvovirus, which is more common in HIV patients and HIV itself, or immune diseases, or a thymoma, PNH. It might be inherited syndromes such as Fanconi's anemia, Discretitis congenita, Schwartzman-Diamond syndrome, non-hematological syndromes such as Down syndrome. So this is a classification of pure cytopenia, that is pure red cell aplasia, neutropenia, and thrombocytopenia. Drugs and chemicals causing aplastic anemia. It might be dose related or idiosyncratic. Dose related, most commonly chemotherapeutic agents such as alkylating agents, carboplatin, followed by antimetabolites such as methotrexate, benzene, antibiotics such as chloramphenicol, sulfonamide, inorganic arsenic. Or it might not be dose related and idiosyncratic, such as in anti-epileptic drugs. Most commonly, we use carbamazepine and phenytoin, anti-thyroid drugs, NSAIDs, and chloramphenicol. Coming to pathogenesis, it has the two major etiologies. One is extrinsic immune-mediated suppression of meroprogenitus by viruses, drugs, or radiation or environment insult, and an intrinsic abnormality of the stem cell, which is further damaged by an autoreactive T cells. So this is a picture showing the pathogenesis of plastic anemia. The stem cell is damaged due to environmental insults such as viruses, drugs, and chemicals. The genetically altered stem cell has a reduced proliferative and differentiative capacity, which results in macroplasia. And this expresses new antigens called as neoantigens. The autoreactive T cells produces several cytokines and bind to this altered stem cell, and which results in the damage to stem cells, which further results in uh, decreased blood cell counts and marrow-aplasia. When we do a cytogenetic study, that is to detect the chromosomal abnormalities by fish karyotyping, that is fluorescent in situ hybridization, or SNPA, 19% show abnormalities, most commonly monosomy 7, which is also most commonly seen in MDS. Trisomy 8 and 13 will have a good prognosis. The cytogenetic abnormalities present does not rule out the diagnosis of aplastic anemia. The next is when we do a next generation sequencing, we can see mutations in P53, which is associated with poor prognosis, or mutation in PGA, which is also very common in PNH, associated with good prognosis. And specific mutation causing telomere shortening done only if there is a shortened telomere length. And the idea of getting a NGS is to rule out other causes such as hypocellular MDS, hypocellular ALL, and hypocellular AML. Coming to morphology, the thing is, you see, if you do a bone marrow aspirate, you will get a dry tab. So the preferred investigation is bone marrow biopsy. And you should do a trephine biopsy, which is 2 centimeter in length, and you should avoid a tangential biopsy. When you see a bone marrow picture, all cells are affected, but the lymphocytes and plasma cells are not affected. Whenever the total cells are less, the fat cells and fibrous stroma become abundant. Okay, next is it affects the granulocytes are less, and there is a thrombocytopenia, and RBC is also less. So this is a bone marrow picture showing predominantly a fat cell and with the stroma and few scattered lymphocytes. Coming to history, the most common is due to thrombocytopenia causes petechiae and ecchymosis, which can present with bleeding. Infection due to granulocytopenia is a late complication. Pneumonia and septicemia are very common. Symptoms of anemia such as easy fatiguability, shortness of breath. But systemic complaints such as fever and weight loss will be characteristically absent in aplastic anemia. If it's present, you should work up for other etiology of pancytopenia. And we need to ask history regarding the prior drug exposure, chemicals, toxins, viral illness to know the cause of aplastic anemia. And we need to elicit the family history because to rule out inherited causes of aplastic anemia. Physical examination, petechiae and ecchymosis might be present due to thrombocytopenia. When we do a fundus examination, retinal hemorrhages may be present, pallor, pallor present, and infections are where signs of infection may be present, but usually at later stages. Lymphadenopathy and splenomegaly are characteristically absent. If present, work up for other causes of pancytopenia and rule out malignancies. And there are a few etiological clues, such as if there is a cephaloid spots and short stature, think of Fanconi's anemia. If there is a nail dystrophy and leukoplakia, think of dyskeratosis congenita. If there is a early graying of hair, suspect telomeropathies. So this is a picture. This is a child of the short stature. So this just with aplastic anemia. Think of Fanconi's anemia. This is a picture showing dystrophy of the nails, leukoplakia, and reticular pigmentation of the neck suggests dyskeratosis congenita. And coming to investigation, the investigation is done under three headings. One is to confirm the diagnosis of aplastic anemia. Second is to rule out the other causes of pancytopenia. And third is to etiological workup. When we do a complete hemogram, the peripheral smear is normal, which is normocytic, normochromic, or mild macrocytosis is observed. A pancytopenia, that is RBC, WBCs, and platelets are decreased. In WBC, characteristically, neutropenia will be there, and the absolute reticulocyte count will be very low. That is, corrected count will be less than 1%. The preferred is bone marrow biopsy. As I said, all cells are affected, but the lymphocytes and plasma cells are not affected. So marrow lymphocytes more than 75% implies poor prognosis. RBCs, platelets, granulocytes, megakaryocytes, all these are decreased, but dysplasia is present. It suggests alternate diagnosis such as MDS. When you say a marrow is hypocellular, we say a marrow is hypocellular when it's less than 30% up to 60 years and less than 20% in more than 60 years. Sometimes you can see a lymphoid aggregates more commonly in autoimmune diseases. And precursor cells are very less, that is less than 25%. And the non-specific findings such as elevated ESR, elevated erythropoietin level, and HB electrophoresis, HbF is increased and iron content might be increased. To rule out other diagnoses, you can get cytogenetics, next generation sequence, as I explained earlier. And we need to get a vitamin B12 and folate levels to rule out megaloblastic anemia. And abdominal USG to look for lymphadenopathy and splenomegaly. If they are present, we need to think of malignancies. And for etiology, if you suspect a Fanconi's anemia, you can get a chromosome breakage study. If you suspect a viral etiology, then we need to work up for viral markers such as HIV, EBV, CMV, hepatitis A, B, C, parvovirus, B19 by serological testing or a PCR. And leukocyte telomere length by PCR or flow fish methods if you suspect a telomeropathies. LFT to detect initial hepatitis ANA and anti-double stranded DNA if you suspect a autoimmune diseases. DCT and ICT if you suspect a autoimmune hemolytic anemia to rule out. And chest X-ray to rule out infection. X-ray radii to rule out Fanconi's anemia. And HLA typing is mainly done for to do a potential donor, especially if the patient is young, we need to try to treat the patient with bone marrow transplantation. And for diagnosis, as I said, it is a hypocellular marrow that is less than 25% with without presence of abnormal cells and any two of the following, that is granulocyte count is low or ANC that is less than 1.5 into 10 power 9 per liter, or neutrophil is less than 0.5 into 10 power 9, or platelet count less than 50,000, corrected reticulocyte count less than 1%, and hemoglobin less than 10 gram per deciliter. Prognosis, if you won't treat, 70% will die, 20% will recover spontaneously. If we treat with good treatment, 75%, but but with bone marrow transplant, survival rate is very high, that is 90%. Idiopathic have a poorer prognosis, toxins will have a better prognosis. Most common cause of death is infections and bleeding. And we should know the grading of severity is very important because it helps in the treatment. The criteria used is Kamita criteria. Severe aplastic anemia is a hypocellular bone marrow with less than 25% with at least 2 out of 3 of the following. That is ANC less than 500, platelets less than 20,000, and reticulocyte count less than 20,000 or less than 1%. Very severe, the same criteria plus ANC less than 200. Non-severe, not meeting both of these criteria is non-severe. And the treatment is, if it is a non-severe aplastic anemia, if the HB and platelets are maintaining, then just observe. There is no significant bleeding or no significant anemia symptoms. We can observe. If the transfusion is dependent, if the patient is transfusion dependent, the treatment of choice is anti-thymocyte globulin plus cyclosporin A. If the patient responds, you taper cyclosporin A as it is nephrotoxic and maintain. If it does not respond, you can repeat the second dose at 6 months. Again, if no response, better is bone marrow transplantation and oxymethylone. And in severe aplastic anemia, if the donor is available, engage, good performance score, preferred treatment is bone marrow transplantation. If bone marrow transplantation not possible due to lack of the donor or elderly age or poor performance scores, then the treatment is anti-thymocyte globulin plus cyclosporin A and L-trombopag, which is a thrombopoietin agonist. And cyclosporin A is a T cell calcineurin inhibitor, which affects the T cell. So here the main pathogenesis is autoreactive T cell. That's why we use the anti-thymocyte globulin and cyclosporin A. And anti-thymocyte globulin is very costly, is bit costly. Those who cannot afford anti-thymocyte globulin, we can use an adenosole, which is an aromatase inhibitor. Complete response if the hemoglobin becomes normal, that for age and gender, neutrophil count more than 1500 and platelet count more than 1.5 lakh. Partial response, they are transfusion independent, that means there will be no significant anemia or bleeding manifestations and does not meet the criteria for severe aplastic anemia. This is the response criteria. And for further information, you can refer to the notes for further details. And thank you for your patience.